Things from Indian Journal of Anaesthesia. I, Dr. Sharma, will be presenting an article published in the April 2025 issue of the Indian Journal of Anaesthesia. It is titled Impact of Early Postoperative Oral Hydration in Pediatric Patients Undergoing Elective Surgery After General Anesthesia, a randomized controlled trial. Traditionally, postoperative fasting lasts for 3 to 6 hours, but recent protocols advocate for earlier oral intake for better outcomes. Pediatric patients poses unique challenges with concerns about vomiting, aspiration, respiratory distress, limiting early hydration practice. Studies confirm the safety of early postoperative hydration in older children, but data on younger children who cannot express thirst or hunger is limited. The FLAG score has been used to guide oral hydration timing, but not as a direct outcome measure. So this study aimed to compare the FLAG scores as a surrogate for patient satisfaction in early versus delayed hydration and assess the complications, clinical parameters, and parental satisfaction. So the primary outcome was to compare the FLAG score as surrogate for patient satisfaction in younger children, and the secondary outcome was the incidence of complications, perioperative clinical parameters, and parental satisfaction. Institutional Ethical Committee approval was taken and trial was registered in CTRI. Participants were ASA grade 1 to 2 from 1 to 5 years of age undergoing elective surgery under general anesthesia. Patients with perioperative upper respiratory tract infection, maxillofacial, oropharyngeal, thoracic, GI, neurological, or laryngeal surgery, altered mental sectors, dysphagia, and parental refusion were excluded from the study. Written informed consent was obtained from all parents and caregivers. Randomization was done using a computer-generated random number table, and they were divided into two groups. The group EH, where early hydration was initiated, and group SH, where delayed standard hydration was given. Outcome assessors were blinded. The patients were kept NP of 6 hours for solids or formula and 4 hours for breast milk and 1 hour for clear fluid. They were pre-medicated with oral midazolam 0.5 milligram per kg 30 to 40 minutes before arrival in the OT. In children without IV cannula, initially inhalation induction was done, under which IV cannula was taken, followed by IV induction. Induction was done with fentanyl and propofol, and according to the type of surgery, duration, and under IV muscle relaxant atracurium, either endotracheal intubation or supraglottic airway device was inserted, and regional nerve blocks were applied whenever appropriate. Dexamethasone 0.15 milligram per kg was given when post-op vomiting of children's score was more than equal to 3. Ringer's lactate 10 to 20 ml per kg was given. Paracetamol 15 milligram per kg and ondansetron 0.1 milligram per kg was given. After extubation, they were shifted to the recovery area, and the FLAG score was measured within 5 minutes of arrival to the PACO. In group early hydration, that is EH, when the modified Eldridge score was more than equal to 9 and patient had normal swelling, cough reflex, vocalization, and stable vitals, hydration was given within 30 minutes of arrival to the PACO. In standard hydration, SH group, hydration after 2 hours or more in the ward as per surgical protocol. If the FLAG score was more than equal to 6 at any time, then Penta 0.5 mics per kg was given. In the EH group, fluid was given by a trained healthcare workers up to 5 ml per kg of 5% dextrose water in any utensil, that is spoon, bowl, or sipper was given, which was administered by the parent, and maximum 2 attempts were taken within a gap of 5 to 10 minutes. Those who rejected were offered breast milk if breastfeeding, and if still rejected, they were excluded from the study. So the primary outcome was the FLAG score at 1 hour of PACO stay, and the secondary outcome were parental satisfaction after 1 hour of PACO stay, heart rate, respiratory rate, saturation, and complications like vomiting, hypoxia. Sample size was based on a previous study at 85% power and type 1 error of 0.05 to detect a decrease in score by 2. A total of 29 per group was taken. Taken a dropout rate of 15%, the total sample size was 33 per group. So this is the concert flow diagram, and this is the baseline demographics between the two groups, which is similar. So here you can see that the primary outcome, which is the FLAG score, it is found that it is significantly reduced in group with early hydration at arrival and at 1 hour. The heart rate, respiratory rate, and the saturation did not differ significantly between the two groups at the PACU in time. So early postoperative hydration resulted in lower flag scores and higher parental satisfaction without significant complications. Previous studies support early oral intake, showing reduced Third scores and lower postoperative opioid requirements. No major complications like vomiting or hypoxemia were observed. Parental satisfaction was higher in the early hydration group, and refusal rates for oral hydration were lower when foods were administered by parents and were more palatable, that is dextrose water. The study's limitations include applicability only to specific surgeries, potential refusal of hydration, and lack of 24-hour opioid consumption assessment. So in pre-verbal and younger children undergoing elective surgery under general anesthesia, for non-complex surgeries with no surgical indication of postoperative fasting, early resumption of enteral hydration within half an hour of PACU arrival has better patient satisfaction in terms of lower flag score and better parental satisfaction compared to children who resume hydration later in the wards. Thank you.